This webinar is going to cover the basic components of an electrocardiogram, known as an ECG or also referred to as an EKG. What I will do is, as I'm going through the various components of the electrocardiogram, I'll also be reviewing the cardiac conduction system and also introduce you to the cardiac cycle and the events, some of the events that take place during certain components of the electrocardiogram. So if we start here, this picture is depicting an electrocardiogram, and what it's showing is from this wave to the beginning of this wave, which I have it labeled right here. That's going to represent all the electrical activity that's observed during one cardiac cycle. And this particular sample, it took 800 milliseconds, which is the same as 0.8 seconds for one cardiac cycle. So if we try to figure out heart rate based on that, you take 60 divided by the length of the cardiac cycle, and you'll get the person's heart rate. So here the heart rate's about 75 beats per minute. Now the SA node, which is the pacemaker of the heart, determines your basic rate and rhythm of your heartbeat, and it spontaneously fires between 60 and 100 times per minute, which corresponds to a heart rate between 60 and 100 beats per minute. Well, I want to show you an example of what sinus tachycardia and sinus bradycardia look like. So what it's easier to visualize is to look at the distance between these large waveforms. We'll talk about in a minute what they are. So look at that. Look at the distance. Now if you look here, the top picture is sinus tachycardia. The distance between these waves is much shorter. The length of the cardiac cycle is shorter. And in this example, it was 440 milliseconds, or 0.44 seconds, which corresponds to a heart rate of 136 beats per minute. Below it, you're seeing an example of an EKG taken from someone with sinus bradycardia. Here, the distance between these waves are much wider, and when it was calculated, the heart rate ended up being 54 beats per minute. The reason why they call these sinus bradycardia and sinus tachycardia, the sinus indicates that this originated from the SA node. Something has caused the SA node to fire at a quicker rate, which resulted in tachycardia. And a tachycardia is a heart rate greater than 100 beats per minute. Sinus bradycardia is something that would cause the SA node to depolarize at a much slower rate, and so the heart rate for bradycardia is defined as a heart rate less than 60 beats per minute. So I just wanted you to see kind of how it looks. Other than in this case, the heart rate being different, everything else is perfectly normal on these EKGs. So let's just start with what all these little waveforms indicate. So if actually I'm going to go back to this picture, is a waveform is any deflections. So an upwards deflection that you see here, or downwards deflection that you see there. Those are waveforms. Segments are these isoelectric things where nothing's really going on. Intervals includes a waveform with a segment. So we'll be going through different waveforms, intervals, and segments as we go along. So we're going to start up in the SA node. SA node is our pacemaker of the heart. It spontaneously fires, generates an action potential, and it will stimulate atrial muscle that's near it to depolarize, plus also we'll be able to get that electrical impulse over to the left atria via the internodal, or not internodal, interatrial band. And so what we're going to see on the electrocardiogram, as the atrial muscle depolarizes, is we're going to see a P wave. So here it's starting to depolarize, still depolarizing, we're coming back to baseline. So the entire deflection, upwards deflection, it represents atrial depolarization. At the peak, The peak of the P wave represents where you have maximum potential difference being recorded by the recording electrodes. As we move down here, it's just still depolarizing, but there's not as much difference being recorded across the electrodes. So at this point here, right there, the atria have finished depolarizing. Where the impulse makes its way down to the AV node. And AV node has few gap junctions. The fibers are small, so we're going to have a delay. Things are going to slow down. And so I'm going to just change the color. Going from here to here, I'm going to see a flat line. This represents that slowing down of the electrical impulse as it moves its way through the AV node, through that bundle His, which is right in here, before it hits those Purkinje fibers. There's no deflection there because we don't have any electrical activity in the muscle being recorded. So we have this little segment where nothing's really going on. So at this point, we're just waiting for the impulse to make its way to the ventricles. Now if we go to the next part, so I'm going to add on, so here was the P wave. Here we are, we're going to define this segment in a moment. You'll notice the next step is to depolarize the fibers in the ventricular septum. Remember, we have a right and left bundle branches. Bundles of Purkinje fibers, which transmit the impulse fairly quickly. The first part of the ventricles to depolarize is the septum. And what we'll see is initially you see a small downwards deflection. Let's see if I can get it to, my hand's working on it, but my pen isn't. Small downwards deflection, followed by a large upwards deflection. I actually need to make it much larger than that P wave, but I just didn't do it. And then we come down with a small downwards deflection here. Collectively, this is referred to as the QRS complex. This Q wave, this small one right here, represents depolarization of the interventricular septum. The big R wave, which you see here, represents depolarization of the muscle fibers, most of the muscle fibers in the ventricles, starting from the apex, moving on to about here. So we see a fairly large waveform. So a lot more muscle, you're going to see a lot more electrical activity associated with it. This S, which is this small downward deflection, is depolarization of the muscle fibers near the base of the heart. So collectively, the QRS complex represents depolarization of the ventricles. What you will notice is the QRS complex is not as wide as the P wave because the ventricles depolarize much quicker than the atria due to the fact that they're the Purkinje fibers that are causing it to depolarize. It travels much quicker. So let's do, let me see, go to the next step, and we'll come back and label some other stuff. So the next step, now before I do the next step, let me fill something in real quick. Okay, so I filled the PQRS in. Now what's going to happen is you see this period where nothing's going on. What we've done is we've finished depolarizing the ventricles. We haven't started to repolarize the ventricles. Once the ventricles begin to repolarize, which is depicted in red on these pictures, we'll start seeing a waveform called the T wave. Okay, so the T wave represents depolarization of the ventricles. It's an asymmetrical wave. It's usually upwards deflected. Now it is wider than you see the QRS because repolarization does not utilize the cardiac conduction system. So it takes longer to repolarize the ventricles than it is to depolarize it. So this all of it, as it's going up and going down, represents repolarization. Most of about the maximum potential difference is being recorded here at the peak. It's just not as much being recorded here, but it's still repolarizing. So this is your basic ECG, your P wave, atrial depolarization, So here's your atrial depolarization. QRS complex, ventricular depolarization with a D, and the T wave is ventricular repolarization. Atrial repolarization takes place during the time when the ventricles are depolarizing, so you will not see any waveforms associated with that. So let's look at some other components of the electrocardiogram. So here we have that P, QRST, so I'm going to fill in some a little bit more stuff. So there's such a thing called the PR interval. The PR interval is from the beginning of the P wave, let's do red, beginning of the P wave to the beginning of the QRS complex, right there. Okay, so actually did not do a very good job of indicating it. So right there. So what it represents is from the beginning of atrial depolarization to the beginning of ventricular depolarization. There are some people that you will not observe a Q wave on their electrocardiogram. There's nothing wrong if you don't see it. And so, but it's still going to be the beginning of the QRS complex. Now, some people will say, well, shouldn't they, on this picture I just drew, beginning of the Q wave, shouldn't we call it PQ interval? But a lot of people, you won't see that Q wave, so they automatically call it the PR interval because most times you'll have the R wave. So PR interval, beginning of atrial depolarization to beginning of ventricular depolarization. What information do we get from it? Big thing is it indicates how long or how well the AV node is conducting. If the AV node is conducting slower than normal, the PR interval will be longer. The normal duration is about 0.12 to 0.21 seconds. So if it's a little bit longer, something's causing the AV node to slow the conduction even more. Technically, if we look right, I'm going to do it in green, is this from the end of the P wave to the beginning of the QRS complex is called the PR segment. That technically represents that delay that's going on in the AV node. In which, what's so important about it, we do want that delay so we have time for the ventricles to fill up. And actually, if we want to correlate some of this to the cardiac cycle, the atria will contract about this point right here, about the peak of the P wave. The atria contract to finish filling up the ventricles, and it's referred to as the phase of the cardiac cycle is atrial systole. So the atria are contracting to top off the ventricles. We're having time before the ventricles begin to contract. The next thing going to look at, next component, is something called an ST segment. So ST segment is from the end of the S to the beginning of the T wave. So remember, segments are isoelectric, so you don't see anything going on. So there's no potential difference being recorded by the recording electrodes. It represents the time between ventricular depolarization and when the ventricles begin to repolarize. This segment should be isoelectric. If it's not, we do have a little gimme where it can be above or below a little bit, but if it's elevated or depressed, it indicates a pathology. It could be myocardial ischemia, a myocardial infarction, pericarditis usually indicates something's wrong. The next thing we'll look at, and it's actually related to the ST segment, is something called the J point, and I'm going to do it in blue. The J point is just right there. The J point is the point at the end of ventricular depolarization. So when the ventricles are completely depolarized, they're completely repolarized, having begun to repolarize, this point will always, always, always be isoelectric no matter what is going on. So this point is a very important landmark. When someone are looking to determine if someone has a myocardial pathology such as ischemia or an infarction or pericarditis, That is our reference point, and we're going to look at these segments that are supposed to be isoelectric and compare it to it. So if these segments, various segments, are above or below about a millimeter above or in regards to voltage, 0.1 millivolt, there is something wrong. So J point's a very good reference or landmark. The other segment I want to mention is called the TP segment. So TP segment is from the end of the T to the beginning of the P wave. Now, like the ST segment, it should be isoelectric. So if this is above or below a millimeter above or below compared to the J point, there's something wrong. The TP segment represents when you've finished repolarizing the ventricles and you haven't started anything yet again. So until you start atrial depolarization, there's no electrical activity being recorded on your surface of your chest or arms, depending on when your electrodes are placed. So that's what we call the TP segment. Now, one last thing I do want to mention very quickly is the QT interval. It begins at that's Q, beginning of the Q, or should say beginning of ventricular depolarization to the end of the T wave. And that would be called the QT interval. It represents an entire cycle of ventricular depolarization and repolarization. That will vary depending upon your heart rate. There's other things that can influence the length of the QT interval. The QT interval, if it's prolonged or short, that could lead to some very dangerous arrhythmias and sudden cardiac death. Some people are born with abnormal QT intervals. Some drugs can affect it, the QT interval, and some ion imbalances also can affect it. But generally right now we're just talking about, okay, this is what it represents. We're never going to give you the normal value because there's a lot of things that determine the QT interval depending on gender, race, and a number of different things. So actually what I want to do real quick is let's go back to the very, very beginning, and I do want to correspond some other things. I did it on one, I'm going to do it in the rest of them. So I'm going to go back here, I'm just going to erase this, I had mentioned that the peak of the P wave represents when the atria begin to contract, so atrial systole. The peak of the R wave right here represents when the ventricles begin to contract. And that would be, they begin to contract during a period called isovolumic contraction. So pressures are starting to build up. They've already completely filled up the ventricles. We want to eject the blood from the heart, but we have to open up the semilunar valve. So pressures have to increase to do that. So the ventricles actually begin to contract about that peak of the R wave. Now, it's not quite, because the T wave tends to be asymmetrical, it's not going to be quite at the peak. It's going to be just off a little bit to the side. During that T wave, kind of like 3/4 of the way into the T wave, is when the ventricles begin to relax. And the ventricles begin to relax during a period called isovolumic relaxation. So, in a way, somewhere in this period right here, ejection had to occur. So you got the pressures up, open up semilunar valves, ejection. Ejection is followed by a period called isovolumic relaxation. So I just wanted to correspond some of the events in the cardiac cycle, or not cardiac cycle, in the electrocardiogram to events that's going on in the cardiac cycle. So this is just a basic overview of the electrocardiogram.